As you are getting your breakfast, we're going to go ahead and get started here, so feel free to pick that up and join us. We're going to be talking about engaging new options to enhance ocular surface and eyelid health. This is a great talk. You're going to learn a lot of things this morning. We've got some exciting updates for you. This is a continuing education activity provided by Vindico and supported by educational grants from Oyster Point Pharma, Tarsus Pharmaceuticals, and Taya Pharma. Okay. Want to make sure you got this when you walked in, but the earlier you access this, the more you'll be able to participate in the fun. So if you scan the QR code, it will give you access to the program. You can participate in the polling, send us your questions, and of course claim the CME credit. And the network Wi-Fi and password is there, all in capital letters. Give you a second. All right. And I'm honored to teach you with my dear friend Dagny Zhu, and we are going to be discussing today how to enhance your ocular surface and eyelid. Dagny, do you want to introduce yourself?
Oh, sure. Hi, good morning, everyone. Thank you so much for joining us. I'm a cornea cataract refractive surgeon in Rowland Heights, California, just like an hour or two north of here, and I've been coming back and forth. I'll be headed there this afternoon for cases, actually, but it's an honor to join, and I'm excited to introduce some of these new innovations that we have for the ocular surface.
Thank you. And just to recap, my name is Lisa Nijam. I am a cornea cataract refractive surgeon in the Chicago area. I have my own practice at Warrenville Eye Care and LASIK, and I'm on faculty at the University of Illinois Eye and Ear Infirmary. And so we will run through this agenda. We'll talk about optimizing the eyelid health, then optimizing the ocular surface, and then go through some real-world cases that I'm sure are similar to what you all are seeing in practice, addressing the pre-surgical dry eye and blepharitis of unknown cause. And so with that, I'm going to go ahead and turn it over to Dr. Zhu.
All right, so let's start this morning with some eyelid health and blepharitis. So these are my relevant financial disclosures. So I'm just going to briefly summarize what we know about blepharitis and some of the updated treatments that we have for it. This was recently published or updated this year, the blepharitis preferred practice pattern by the AAO. And here are some of the key points that I'm going to review briefly over the next few slides in terms of the highlights that the committee want us to know about blepharitis. Basically, it's still a chronic condition. There's no cure, so we have to remind our patients of that. But there are a number of therapies available. So here's a very long list of causes of eyelid inflammation or blepharitis, ranging from infectious causes to autoimmune, but even neoplastic and traumatic. And so the committee for the preferred practice pattern for blepharitis wants us to remember that for refractory cases, blepharitis that's not getting better, think about the less common causes, especially carcinomas, neoplasms, especially if you see missing eyelashes or misdirected eyelashes. So it's something to keep in mind. Less common cause, but something we should always keep in the back of our minds. So it's important to differentiate still between anterior versus posterior blepharitis. Anterior being most of the signs in the lashes caused mostly by bacteria like Staphylococcus. You see misdirected lashes, missing lashes. You can see those sterile marginal infiltrates, whereas posterior blepharitis is more along the meibomian gland, posterior eyelid margin, and that's where you get your evaporative dry eye disease. And there you don't see as many changes in the lashes, but you definitely see, inspissated meibomian glands. And frequently it's associated with rosacea. So we're going to talk a little bit about both anterior and posterior blepharitis today. Here are the conventional treatments that we've tried over the years, kind of tried and true, but still a gap in terms of what can serve our patients, but these are some of the methods that we typically start with. And you can see the long list here. Artificial tears, Dr. Nijam's actually going to talk about some of the updates that we have in terms of the ingredients that can be helpful even for evaporative dry eye disease. And there's a long list of antibiotics that can be used to help reduce some of that bacterial load, especially for that anterior blepharitis that I was talking about. I think there's been a shift away from tetracyclines because we know there's side effects associated with that, GI upset, photosensitivity in our skin, can't use in pregnant women or children. And so there's been a shift towards oral azithromycin and erythromycin. And so here are just some of the dosing guidelines for kids and adults if you'd like to implement that in your practice. The dosing is a lot easier also than doxycycline because a lot of it is pulsed, just a couple days each week or even 1 gram per week for azithromycin oral for 3 weeks compared to 3 months of doxycycline BID. In terms of additional treatments, we could have a whole nother talk on oral omega-3 fatty acids and which ones work, which ones have efficacy. I also like to start with some sort of anti-inflammatory agents, especially for patients who are very symptomatic. A short course of steroids are very helpful, as well as the long-term anti-inflammatory treatments for dry eye disease. And then there have been a number of studies on in-office procedures for treating the glands, specifically vector thermal pulsation. You heat up the glands and it helps you to massage it out and open up those orifices in office, as well as microblepharoexfoliation, where you're treating more of that anterior blepharitis, getting rid of that scurf. IPL has had some pretty good efficacy, as well as manual gland expression, manual gland probing in office. But it's important to remember that while there are studies showing efficacy for each of these, there's really a dearth of randomized controlled trials and good data showing superiority of any of these treatments over another. So that's kind of the long list of what we've had for a long time, and there's been kind of a lull in innovation for a long time until very recently, right? So it's super exciting that we have now these 2 new recently approved pharmaceuticals for blepharitis, specifically Demodex blepharitis, which is treated with lotilaner. And I'm also going to be talking about perfluorohexyl octane, which is the first eye drop for evaporative dry eye disease. So super exciting. I'm going to talk a little bit about selenium sulfide, which is currently still in trials, but we can expect to see that soon. So when you see a patient in your clinic with blepharitis, they manifest pretty frequently with erythema, red eyelid margin. But how do you know if it's Demodex? So if you look at that bottom picture there especially, you see there are some cylindrical sleeves at the base of the lashes. And that is pretty pathognomonic because we know that collarettes represent mite eggs, debris, and waste. Take that in while you're having your lovely breakfast this morning. But that is exactly what it is. And that's why it is pathognomonic for Demodex blepharitis. And so in the pivotal studies, they enrolled patients with grade 2 to grade 4 Demodex blepharitis, which is considered clinically significant. And you can see pictures here. Grade 2 is when they have collarettes on 10 lashes to 1/3 of the entire lash per eyelid. Grade 3 is up to 2/3 of the lashes, and grade 4 is greater than 2/3 of the lashes per eyelid. And so lotilaner, it's the first agent that's been approved for Demodex blepharitis treatment. It just came out in 2023, and it was shown to significantly reduce collarettes, decrease or completely eradicate mites, and reduce eyelid erythema after just 6 weeks of BID dosing. And what's the mechanism? Well, it targets the mites directly, and it paralyzes them, and it causes them to die. So that's exactly what we want. Interestingly, the lipophilic nature of the drop enables this drop actually to flow into the lash follicle. And so there's some evidence that it even helps to break up some of the meibum and open up some of the orifices. There was no scrubbing or rubbing was permitted in the clinical trials, but this drop was allowed to flow into lash follicle to better penetrate and reach those mites. So here are the pivotal Saturn studies, and we see that the primary endpoint was met. So this was a complete collarette cure, grade 0, meaning that less than 2 lashes per eyelid had collarettes after 6 weeks of treatment. And you can see that with treatment, it was about 50% of patients had a complete collarette cure compared to only 10% of the control. But when we look at not just complete cure, but significant clinically meaningful reduction, that is grade 1 collarette grading, that number actually increased to 85%. So 85% of patients had a grade 0 or grade 1 result after 6 weeks of treatment, compared to only 28% for control. And you can see that also there were significant improvements with mite eradication and even lid erythema cure. A lot of that redness went away compared to the control. So recently, the results of the extension study were just published in 2023. So these were patients who were enrolled in the pivotal trials, had the 6 weeks of treatment, and were followed for 180 days and even up to 1 year. And they showed that efficacy in terms of reaching grade 1 or grade 0 collarette reduction was sustained over that first half year and even up to a year, and it was tolerated very well. So here are the specific results. You can see that in terms of the complete collarette cure, grade 0, up to 365 days, we still had patients in the Lotilaner group showing complete cure at a greater rate, 24%, compared to only 3% with the control. And then when we looked at grade 0 and grade 1, it was still up to 62% of patients in the Lotilaner group had that grade 0 or 1 at 365 days, compared to only 22% with control.
I was involved in this study, and this actually stat is one of the things that I quote for my patients all the time, because I think it speaks about the long-term efficacy of Lotilaner. So I think it's a really important one that you brought up.
Yeah, you can see the graph there and how it's a nice plateau. Like, it doesn't really drop off after that initial 43 days that they looked at in the pivotal studies. It continues to maintain that control up to 180 and 365 days. Although there are some patients you'll notice that do have some recurrence, right? They end up having greater than grade 1, and so it's something to keep in mind when you're counseling your patients, that you may need retreatment if it were to recur over the first year or later. What's interesting was the erythema cure. The erythema cure actually improved over time. So up to 365 days, more patients actually had erythema cure. So it seemed to continue to reduce that eyelid redness even over time. The efficacy continued to improve, it seems, over that first year. In terms of safety and tolerability, it's a very tolerable drop. Most of my patients don't really have any issues continuing it. In the study, 10% of patients did report temporary stinging and burning with instillation. But overall, 90% of patients in both the vehicle and the treatment group said the drop was neutral to very comfortable, so very tolerable for our patients. And in terms of the 1-year study, they didn't really see any significant adverse events related to treatment. These were things like visual acuity was kind of impaired or decreased, but that was seen in both groups, the treatment and control. So it wasn't deemed to be treatment related. So it didn't seem like there were any safety issues over that first year. So the second drop I'm going to talk about, that was more anterior blepharitis. We're going to talk about evaporative dry eye disease, which is caused by posterior blepharitis or meibomian gland disease. This is the first drop perfluorohexyloctane that has been indicated for the treatment of evaporative dry eye disease. And here you can see there's an unstable tear film in patients with evaporative dry eye disease. And when you add this molecule, because of its lipophilic hydrocarbon segment on one end and the aerophilic segment on the other end, it kind of lines up and it kind of integrates into the air film tear interface to form a barrier that keeps the aqueous from evaporating. And so that's what we're doing. We're coating the surface of the eye with a nice protective layer. And this is the one with dual mechanism of action, where it prevents evaporation but also penetrates into meibomian glands to dissolve thickened meibum. So earlier I said that was for Lotilaner, so I actually meant it for this drop here, perfluorohexyloctane. So the Gobi and Mojave phase 3 pivotal clinical studies showed pretty much significant improvements in terms of both signs and symptoms. So at day 57, there was a significant decrease in total corneal fluorescein staining, as well as improvements in patients' dry eye symptoms based on a visual analog dryness scale. And what's interesting is that This endpoint was met at 8 weeks, but patients showed significant improvement in both signs and symptoms as early as 15 days, which is huge because we don't have that many dry eye drops that work that quickly. So when you do have signs and symptoms improving at 15 days, it's pretty remarkable, especially for patients that were trying to get ready for surgery. Again, very tolerable. This is probably one of the most comfortable dry eye drops you're going to encounter, with very few patients complaining about burning or stinging on installation. It's extremely comfortable, and because of the small size, honestly, most of the time they don't even feel it going in. The most common AE in the studies were temporary blurred vision, as well as some blepharitis, blurred vision, unclear if that was related to treatment or not, as well as conjunctival hyperemia, conjunctival papillae, but that was seen again in both the treatment and control groups. So currently there is an extension study also going on for this drop, assessing the safety over 1 year. It's the Kalahari study, and hopefully those results will be out soon. And then really quickly, I'm going to talk about selenium sulfide. So this is a medication that is still undergoing trials right now, but it would be the first ophthalmic ointment targeting specifically the meibomian glands. So this is the same ingredient, selenium sulfide. It's the same stuff that you have in your anti-dandruff shampoo. And it has a cherolytic mechanism of action where it breaks the disulfide bonds in the meibomian glands, which theoretically would unblock the orifices and also decrease meibum viscosity. So here are some of the phase 2 studies outcomes showing that there was significant improvement in terms of the number of meibomian glands yielding liquid secretions, and there was also a decrease in ocular surface disease index total score compared to the control. And they evaluated at 2 different concentrations, which seem to have similar efficacy. The main issue with this ointment is the AEs. You'll see the most common one was application site pain. So, up to 15 to 17% of patients do complain of some burning and installation site pain. But otherwise, it was seen to be relatively safe. So that's exciting in terms of all that we have now available to better treat our patients with blepharitis and evaporative dry eye disease, and kind of some of the things that we can look forward to in the near future as well.
Thank you. Thank you, Dagny, for that excellent talk. As we move from the lids to the ocular surface, I'm going to discuss optimizing the ocular surface. These are my relevant financial disclosures. Okay, so in this portion, we're going to talk about some newer solutions to optimize the surface, preservative-free OTC tear substitutes, brief overview of newer formulations for dry eye disease, and some newer therapies targeting novel mechanism of action. So I want you to meet Ben. Ben is a 54-year-old man who works in finance, trust fund, blue eyes. We know who's on social media who gets that. All right, so 54-year-old man who works in finance. He does not have time for dry eyes. I was really entertained with myself when I came up with that one, but I'm glad you liked it. He's a contact lens wearer. He reports some dryness, redness, irritation, foreign body sensation, sandy, gritty, both eyes. You guys have seen patients like this, yes? He works on 3 computers. His vision in the right eye with correction is 20/50, and the left eye is 20/70. He's got some meibomian gland dysfunction in both eyes, some scurf, no sleeves, apparently. Corneal staining, you'll see that in a minute. Tear breakup time is about 5 to 6 seconds in both eyes. His osmolarity is elevated at 327 and 333. He's got a positive MMP9. And he tried 2 kinds of drugstore artificial tears, no improvement. He was given cyclosporin 0.05% and he reported back that it burned and he could not tolerate it. So that's what his corneas look like. Some decreased tear breakup time, some irregular staining. So this is where you're gonna come in. You're gonna help. We need you to help Ben. Ben has a lot of questions, and so we're gonna try to answer them one at a time. So does it matter what artificial tear that I use? So go ahead and please pick up your phones and scan the QR code. And let us know, does it matter which formulation of artificial tear he uses? Yes, no, not sure, or anything is fine as long as it's preservative-free. This is the dancing portion. Bless you. Oh, all right. 83% of you said yes, it does matter. All right, let's see if you're correct. Well, indeed you are. So not all artificial tears are created the same. The chart that you see on the left, FDA-approved emulsants for artificial tears by groups. I'm not sure if everybody knows this, but there is usually a list, or there's a menu that the FDA has approved for ingredients for artificial tears that when you formulate an artificial tear, you can choose from these ingredients to place them into artificial tears. And this is also why we have so many different artificial tears on the market, because as long as you have one of these or some of these ingredients, you can pretty much put it on the shelf. The most notable and widely used ophthalmic demulcents are carboxymethylcellulose sodium and hydroxypropyl methylcellulose. Say that fast 3 times. But the truth is that ingredients do matter, and hyaluronic tears, it's actually the most common tear used. Viscoelastic property that thickens the tear film when the eye is open and thins when the eye is closed. The thicker tear film helps protect that corneal surface, and the ocular surface remains moist, and it creates a thicker tear film without the blurring. So when you have HA in tears, you get greater retention time of the tears, less blurring than conventional tears, and that results in improvements in comfort and quality. And you may have heard, we actually recently published a paper on osmolarity. It's going to be coming out this next week. We know that hyperosmolar patients tend to have difficulty with light scatter, particularly after cataract surgery. It can actually cause the equivalent light scatter to grade 2 to 3 cataract. So when you have a patient and they're having a difficulty with their vision, particularly post-op, you may want to check the osmolarity to see if that's part of the cause of your problem, because the HA in the tear, you can see how it helps time 0, that blue cross, no drops, 5 minutes after installation, the green circles, and then 15 minutes after installation, you can see how much more stable and how much less light scatter you have. All right, so other ingredients that could be in artificial tears, trehalose. Trehalose is actually a fascinating molecule. It's a natural A-linked disaccharide formed by an alpha-alpha-1 and 1 glucoside bond between 2 alpha glucose units. And it's actually found in a lot of things in nature that I didn't know about till I started researching this. It's one of the reasons why some little insects can remain alive for so long. It's something that's kept in their exoskeleton and allows them to last those time periods of very dry circumstances. If you put it for your plants or your flowers or your tomatoes, they will actually grow and last much longer because it protects, keeps the moisture in. And so you can see that control flower that's without any trehalose, and then the pink one with the trehalose and the sucrose, and that allows the plant to retain the moisture. I'm giving you gardening tips along with your dry eye treatment. It actually prevents desiccation and high osmolarity by protecting cell membranes and proteins from denaturation and disruption in the absence of water. So it allows maintenance of integrity during drying and rehydration. And so you can also combine the trehalose, the HA, and the povidone, which can form a very powerful formulation when you're looking at the individual components that come together to create kind of an elevated artificial tear. And there's data that shows, data on artificial tears, yes, that preservative-free trehalose and HA-containing eye drops decrease dry eye symptoms. They decrease ocular discomfort on the OSCI and VAS scores and led to improvement in patient-reported symptoms that was statistically significant. And again, the same study showing HA and trehalose had significant increase in the tear film thickness at all time points out to 240 minutes after administration. So that's a very long time, and you know that's one of the most common complaints when patients use artificial tears, right? They feel they put it in and then it evaporates right away. So this one actually, again, data showing 240 minutes that effect was lasting after administration. It also improved tear breakup time and symptom severity. So we've answered Ben's first question. Ben has another question. Should I go back on the cyclosporin 0.05%? You recall he tried it and he felt that it was burning. So here there are different FDA-approved cyclosporin formulations. As you know, cyclosporin is a hydrophobic molecule, and so the formulation makes a difference for patients and their ability to tolerate the drop. In 2023, there's cyclosporin 0.1%. Perfluorobutylpentane is the vehicle there, showed a primary endpoint of 29 days. There is no water in that drop, so there's no pH, had 8% tolerability. 2002, the earliest one, was 0.05%, and you can see the data there. And then 2019, we had cyclosporin 0.09%, showed efficacy at 84 days. And again, the pH between about 6.5 and 7.2 with about 22% tolerability of instillation pain. There's also loteprednol and tabinate, 0.25%. This is actually something I use routinely in my practice. It's the only FDA-approved steroid for short-term treatment of signs and symptoms of dry eye. It does contain a proprietary mucous membrane particle coating that helps increase diffusion of the molecule into the ocular surface. All right, Ben has another question. I don't have time for dry eyes, and I don't want to put in any drops that sting. What other options do I have? All right, here you are, audience. Ben has another question. If you can scan the QR code and let us know, are there other options that may be used as first-line treatment? A, the ones I use, the class of drugs I use have already been mentioned. B, I don't know of any drops for dry eye disease that do not sting. C, punctal occlusion, or D, something else. You really got me going. You got me so. All right. Okay, 10%, the ones we mentioned are the ones you use. 47% would do punctal occlusion, and 43% would do something else. So here's a chance for us to all increase our knowledge on what options we might have for Ben. So Dagny mentioned perfluorohexyloctane. I actually, again, use this drop pretty routinely in my practice. It's the newest approved medication for evaporative dry eye and really all of dry eye signs and symptoms. It's got low surface tension, it's fast spreading, lubricating, and film-forming properties. It's preservative-free with minimal visual blurring. There's very minimal, it's less than 0.5% burning, stinging. This creates a coat on the ocular surface that really helps the patients with improving staining, especially central staining, and improving comfort. And it works right away. There's actually, there's some new data that you'll see that's coming out that shows, improvement almost immediately within the first hour. In the Gobi and Mojave studies, both signs and symptoms endpoints were met, which is really unique for a treatment for dry eye disease. And then we come to some newer mechanism of actions as well that's really important for you to know for your patients. So trigeminal parasympathetic pathway. Is anyone familiar with that? Do you remember that, medical school? It plays a role in tear film stability. It's responsible for tear film production and promotes natural tear production when inhaling air through the nose. So remember, the trigeminal nerve is accessible within the nasal cavity and can be activated by stimulating nicotinic acetylcholine receptors, and this becomes important in a moment. So when you stimulate the trigeminal sympathetic pathway, you cause the eye to release what are natural tears or real tears. And so that would beg the question, well, what's different about natural tears or real tears? What do you see? And when we look at it, you actually find that the tear film is fascinating. There are over 2,000 molecules of various functions, growth factors, immunopeptides, anti-inflammatory, metabolic enzymes, and more. And of course, it has the liquid, mucin, and aqueous components that we're all familiar with. But there are actually over 2,000 molecules that are in those, in your tears. So when we do tear neurostimulation with varenicline nasal spray, that's a highly selective nicotinic acetylcholine receptor agonist that activates this pathway and stimulates the lacrimal functional unit to reestablish the natural tear film. And it's delivered as a nasal spray. So for those of your patients who are tired of using drops, who don't want to use drops anymore, who are really concerned about stinging of drops, this offers a completely different mechanism, a completely different way for you to treat your patients and to result in those stimulation of tears. It was shown in a pivotal study to improve natural tear film production by over 10 millimeters in 50% of the patients when they test with Schirmer's. So you can see the results there of varenicline in onset 1 and onset 2, 52% improved in onset 1 to 14% of the vehicle, and 47% in onset 2 to 28%. It also showed the onset of action as early as about 5 minutes following the first dose, and the mean change after the first administration of varenicline in 5 minutes. The mean change was 17.2 in the onset 1 and 16.5 in onset 2. And again, that's Schirmer's testing. Safety and tolerability, always important when we talk about any medications. Sneeze was the most common AE. But, you know, I tell this to all my patients, expect that you're going to sneeze initially. This gets better, this gets less as you use the nasal spray. And the important thing is over 98% reported that the TAEs were mild in severity. Treatment completion rates in the initial study were greater than 93%, and there was no significant difference in the SAEs and the ocular AEs. So in short, for varenicline, significant improvements in the signs, the Schirmer scores, and some nominal improvements in the symptoms, the eye dryness score by day 28, rapid onset of action, about 5 minutes for those patients who want things right away. And the consistency of effect was shown across age, ethnic, menopausal status, artificial tear use. There's safe and well tolerated, and most common side effect was sneeze. So is there any chance that Ben has Demodex? Dagny did a great presentation there earlier on Demodex. Is there any chance that he would have it?
So it's possible.
Before I would have told you no, or before I would have told you my suspicion is less. However, just recently in ophthalmology, just not even 2 weeks ago, there was a case report that was published I found fascinating. This was a patient who was complaining of ocular discomfort. They tried some traditional treatment measures. They were not able to get him to improve. And then they decided to express one of his meibomian glands and look at the contents under the microscope. And sure enough, even without sleeves on the eyelid, 15 Demodex brevis came out of the expressed meibomian gland. So previously, I might not have thought about that, but it is something to consider and something to think about.
So there were no collarettes in that case? They didn't.
Zero. Yep, they didn't have any.
So even though collarettes are pathognomonic for DB,
correct,
not having collarettes doesn't mean you don't have DB.
Exactly. And so that was a fascinating case report that I wanted to make sure I included. So we are going to jump into the cases now. And again, this is your chance to participate with us. We're going to talk about addressing pre-surgical dry eye. This is a 68-year-old woman with dryness, grittiness, and blurred vision. She drives herself and is taking her driver's test in 2 months. She needs to see better now. She's worried about her driver's test. She's the primary driver. She's tried some over-the-counter artificial tears. She is menopausal, feels everything is drier now. Rheumatoid arthritis, hypertension. She's about 20/80, 20/60. 1+ conjunctival injection, 2+ chalasis, osmolarity elevated at 330 and 322. 2+ nuclear sclerotic cataract in both eyes and the ocular surface as shown. And you can see that she's got some irregularities there on the ocular surface. You might want to look carefully at that photo, and irregular staining. And so here you go, guys. What are you going to do? What would be your next step for this patient? A, preservative-free tears, then cataract surgery. B, preservative-free tears, prescription dry eye med, superficial keratectomy, then cataract surgery, a superficial keratectomy, then proceed with cataract surgery, or would you do something else entirely? Please scan the QR code with your phone and let us know. All right, 53% would choose option B. We had some people who are going to do some preservative-free tears and cataract surgery, and 20% that have another approach. Then she mentions that her rheumatoid arthritis has gotten worse. I know it's always that second pass that the patient comes up with other things to mention to you about. So in this case, because she was having more difficulty putting in eye drops, and because she was, it's something I think to be aware of and something to be knowledgeable for, is that patients do sometimes need alternatives to traditional drops. We have excellent drops now to treat ocular surface disease, and I use them all the time. But at the same time, I've also incorporated varenicline as part of my routine treatment for dry eye patients because of the effectiveness, as you saw in the clinical case studies, and also because sometimes patients need an alternative route. So I always recommend high-quality HA preservative-free artificial tear, and in that case, there was indeed EBMD in that patient. And so I did a superficial keratectomy followed by cataract surgery 1 month later. She ended up 20/20, and she continues to be able to drive. So it was a successful result. Another reason I would consider varenicline in this patient is we did do a post hoc analysis of the results from the Onset 1 and Onset 2 trial, looking particularly at menopausal status. As you know, as women, it's a driver for dry eye, particularly in that age population. And so I do think it's important for us to start paying attention to data on that and ways that we can help the postmenopausal female patients also with their dry eye disease. And so the results of that were that the varenicline solution had similar efficacy in promoting that natural tear film production in groups that were both postmenopausal and non-menopausal. And so there's conclusion that evidence can support use of varenicline in this vulnerable patient population. And again, postoperatively, always important to continue. Make sure that your patients understand that ocular surface disease is not a one-time treatment, but that you need to continue that after cataract surgery to ensure that you're going to have those results. So I always try to explain the chronic nature of dry eye disease and the need to continue treatments post-cataract surgery to ensure that we maintain the great results that we get from cataract surgery.
So the main reason you recommended the varenicline spray in this case was because of her arthritis and perhaps difficulty administering the drops. If she didn't have arthritis, would you have considered, like perfluorohexyl as a first-line agent as well, or wouldn't you consider maybe a topical steroid to help with symptoms, or even punctal plugs in this case?
Yeah, all of those. I use all of those routinely in my practice. I think that, again, personalizing the care for the dry eye patient to what they their other perhaps physical abilities / abilities to tolerate medication / whatever their ocular surface appears to be. So those are all viable options as well, depending on what the patient can tolerate. I will end here. If you have any questions, please reach out to me. Thank you very much for your attention, and we will go to our next case.
All right, so thank you, Lisa, for that awesome case. So we're going to go back now to the eyelid margin and blepharitis. And this is my case. So this is actually a patient I recently saw. He was a 65-year-old man, history of hyperopic LASIK elsewhere many years ago. And I did routine cataract surgery in both eyes on him back in 2022. And he had a great visual outcome. His vision improved quite a bit. But after that time, he's just never been happy for the 2 years since his cataract surgery. He had a right lower lid hordeolum in 2023. And every time he comes in, he complains of tired eyes, foreign body sensation, itchy eyelids, burning, blurred vision both eyes, sees double in both eyes. So even though he's, 20/20 on paper, he's not very happy with me. So how many of you guys have patients like that in your practice, right? So those are the hardest ones to treat. So in my practice, I actually have several in-house optometrists who do a lot of the clinical exams for me post-operatively. And sometimes they bring cases to my attention, and sometimes they don't. And so this particular patient has been managed by my in-house optometrist for the past 2 years. And finally, the patient's had enough, and he said, today, I want to speak with the surgeon. So, the optometrist comes and says, the patient's waiting for you in room 2, and, that's never a good sign. You have to take a deep breath before walking into those rooms. So you look through his chart, you review his current and past therapies, and he's tried everything that I went over in my first lecture for blepharitis, artificial tears, warm compresses, hypochlorous acid spray to decrease some of that bacterial load. For anterior blepharitis, he's been on steroid tapers, tetracycline, cyclosporin. For that itchiness, he's tried a lot of topical antihistamines. None of it has been working. He said the only thing that maybe brought some relief was an in-office vector thermal pulsation treatment that he had 6 months ago, but even then, maybe he felt better for 2 weeks. It was just temporary. So he's basically tried everything, this patient with blepharitis. You review the exam that the optometrist did for the day. Again, his vision uncorrected is pretty good, right eye 20/25, left eye only 20/50, but you're able to push him to 20/25 with refraction. So that is a key finding that this may all be related to ocular surface disease when they have fluctuating vision that you can push better if you tell them to put greater effort. And then, of course, on exam, you see quite a bit of blepharitis, mostly posterior, with meibomian gland dysfunction, grade 2 or 3, documented by the OD, with thickened gland secretions. Eyes are both a little bit red. He's got quite a bit of staining in both eyes with decreased tear breakup time. And so classic signs of posterior blepharitis with dry eye. So what do you do? So you go in, sit down, and have the patient look down just in case the optometrist missed something. And you turn up the magnification all the way. And phew, I lucked out. He has like a row of colors. This is a real picture of my patient from literally 2 weeks ago. I had my optometrist come take another look and take photos because they know that they're supposed to have every patient look down because we're not supposed to miss collarettes and Demodex. But in a busy clinic, sometimes you still forget to do so. And so I was very relieved. And these days, I'm so relieved when I see collarettes because there is treatment for it now. So honestly, if I don't see collarettes, I'm a little disappointed because I know it's going to be a tougher case to treat.
Has everybody seen collarettes? Have you guys seen collarettes routinely? Yeah, it's interesting because up until this treatment became available, just to be frank, I didn't look. I would look and I would see scurf and, sleeves and whatnot, but I didn't spend much time thinking about it past that. especially if they weren't complaining. But it is amazing if you just have patients look down and you will identify so many patients that have collarettes and sleeves, and then some of their complaints start to make sense. And so it's something that really takes just a few seconds. And, if you just take that extra second to look, have them look down, you'll be amazed at how much you can identify.
Yeah, I agree with you. I'm guilty as well. I did not really look closely for it until more recently when we're learning more about it. We're taught to look at the meibomian glands, push on the lid, look at the quality of the secretions, but often we're doing that with the patient looking straight ahead or even up, not looking down, right? So it's a crucial step that we're missing. But with those, 3 seconds, you could be the eye care provider that diagnoses something that's been missed for years by another eye care provider. So you can make a huge difference in your patients' lives. So again, seeing collarettes, we know this is 100% Demodex blepharitis. And what causes Demodex? It's these little creatures. Brevis, which is a smaller Demodex, lives in the meibomian glands, and follicularum, which is twice as large as Brevis, lives in the hair follicles. And they're causing lots of inflammation and destruction in the glands there. And so it's actually, as we discussed, more prevalent than we realize. So in this study, it was found to be up to 69% of blepharitis diagnoses. So more than half of our patients with blepharitis actually have Demodex. More than 60% of patients getting dry eye prescription treatment have Demodex. It's more than half of our cataract patients, and even about half of contact lens users. So even in younger patients, I'm seeing Demodex more often, especially with those eyelash extensions. I've seen so many of those patients with poor eyelid hygiene and Demodex as a result. So we talked about some of the clinical manifestations before. So it is a type of anterior blepharitis. So you will see disordered eyelashes sometimes, missing eyelashes. We see that lid margin inflammation or that erythema, again, pretty commonly. In more severe cases, you can get corneal manifestations similar to other types of severe blepharitis. You can see flictinules, you can see marginal infiltrates. And then these eyes, they just never look healthy. They're always a little bit red. The conjunctiva is always inflamed. So how much does this actually bother our patients? I would say they're pretty symptomatic. So Atlas was a study that actually looked at this, patients with at least 10 collarettes on the upper eyelid and mild erythema. And, more than half of those patients complained of itchy eyes. So again, that's the most common symptom, I feel like, for Demodex is itchy eyelids. And these patients are often misdiagnosed as having allergy. So remember, they're probably on topical antihistamines that haven't been helping. So that's one thing to keep in mind. And then it's associated with, typical symptoms of ocular surface disease, feeling dry eye, foreign body sensation, tearing, watery eyes. So these patients are constantly conscious of their eyes all day. And so it has a pretty negative effect on their activities of daily living. The Atlas study also showed that there's an unmet need, right? So we talked about this also. These patients are not getting diagnosed. Half of these patients are having signs or symptoms on average for more than 4 years. And half of them, more than half, have never been diagnosed with blepharitis at all. And then 33% of these patients have seen eye care providers over and over more than 2 times, 15% more than 6 times, and have not received the proper diagnosis. So you guys have the tools now to make sure you don't miss it the next time a patient like this walks into your office. So polling question, now that you have this patient that you've diagnosed with Demodex, what would you recommend? So there's a variety of options here, and many of them we've tried already. So it'll take some time for you guys to put in your answer. Okay, so, yes, I was a little scared. I was like, oh my gosh, no one wanted to prescribe Lotilon after I spent that whole time talking about the results. But tea tree oil wipes I saw was also 48%. So, tea tree oil, has some efficacy. It was definitely my go-to treatment before Lotilaner came out, but that stuff burns. A lot of patients can't continue it for a very long time, and it doesn't really address the root of the cause, and so frequently the Demodex is coming back. So Lotilaner, again, is the first FDA-approved treatment that we have for Demodex blepharitis, and we've seen with the extension study that the outcomes last significantly, even for up to a year. So I would definitely try to get your patient Lotilaner, and that's what I did for mine. I prescribed him Lotilaner 0.25% twice a day for the 6-week course. This is a recent patient, so I'm still waiting for him to come back, but if he's like any of my other patients, I expect, remarkable improvement and reduction in his collarette load. But anytime you have a patient who's just not improving, you've tried everything for blepharitis, make sure you have them look down and think about Demodex. So thank you so much.
I think the important thing for me with that difference has been with the difference between tea tree oil and Lotilaner. I've used tea tree oil for years as well. But that extension study really made the difference for me. I mean, tea tree oil does burn, but then also to be able to say that 62% of patients, you're just going to need this one 6-course treatment, and then it's going to eradicate your Demodex. That makes a big difference. And patients are much more willing to do that for 6 weeks than they are to use tea tree oil that there's going to continue to come back or continue to burn and maybe give them only temporary relief from their symptoms. So in the last few minutes, we're going to do our post-test. If you can please scan that QR code to participate if you have not already. We're going to run through these. In a randomized controlled trial, preservative-free HA plus Trailose containing eye drops resulted in significant increases in tear film thickness at all time points up to blank minutes after installation. 60, 120, 180, or 240. All right, nice job. You were listening. It's indeed 240 minutes. It always makes me happy. All right, next question. In the pivotal onset trials, varenicline nasal spray, A, increased natural tear production by greater than 10 millimeters in 25% of participants, had an onset of action as early as 5 minutes following the first dose, had treatment completion rates of almost 70%, was associated with a significant increase in frequency of ocular AEs. Very nice. Yeah, the greater than 10 millimeter increase is about 50% of patients. Treatment completion rate is 98%, and obviously an insignificant amount of AEs. Great job. What proportion of participants received Lotilaner ophthalmic solution in the combined Saturn trials achieved clinically meaningful collarette reduction to grade 0 or 1 at day 43? 55, 65, 75, or 85? All right, very good. 85%, excellent. All right, and I think this is our last one. Which option below would you recommend for managing a dry disease flare in a patient who has struggled with administration adherence to topical medications prescribed in the past? Short-term treatment, topical loteprednol etabinate, the 2-week course, topical cyclosporin or flitigrest, oral corticosteroid, varenicline nasal spray twice daily, or punctal occlusion. All right. There's really no wrong answer to this one. I didn't want to tell you ahead of time. But any of these options are reasonable. Again, I think it is really important to personalize care to your dry eye disease patients and figure out what works best for them and their particular signs and symptoms. But don't forget that there is a nasal spray that is available to treat that has some great results. So due to time, if you submit any of those questions, we will do our best to answer them after the panel in the back of the room. I want to thank everyone for being here. Thank my co-presenter, Dr. Zhu, for a great presentation. The educational content will be developed into a micro CE podcast that will be available for streaming and download on Helio, MedTalks, and other popular podcast platforms. To view online and earn additional CME credit, you can go to helio.com or medtalks.com and search for ocular surface and eyelid health. It's also available to a short form video highlights within the meeting app. Our next CME Spotlight session is going to be lunch, novel treatment plans to prioritize real-world visual improvements in patients with macular degeneration and diabetic macular edema. It will be here starting at noon. And please be sure to complete the evaluation on your mobile device by scanning the QR code or clicking on the link to claim your credit. So thank you again, and have a great Saturday.